I'm going to invite Dr. Axel Grothey to the podium for some comments about metastatic colon cancer, something that we all continue to deal with on a daily basis. Should be very helpful. Dr. Grothey joins us from the Mayo Clinic in Rochester, Minnesota. Welcome.
Thank you very much for having me here. It was actually a lot of fun running through the woods here. I didn't meet a bear earlier today, so I was safe. And no fire smokes. In the morning I heard it was a problem, but it was great. Somehow I was very lucky. Metastatic colorectal cancer, and colorectal cancer is a very interesting tumor. We have hereditary syndromes, we have biologics that we use, we have made amazing advances over the last 1 or 2 decades, and at the very end of my talk, of course, we need to talk about immunotherapy, because we are getting immunotherapy in colorectal cancer right now. What I'd like to do is kind of give you a ride through the management of metastatic colorectal cancer and where we're going in the future. So just to give you some overview, where are we right now? So first of all, we have to acknowledge some patients with metastatic disease can be cured. When we use a multidisciplinary team, we resect liver metastasis, lung metastasis. 10 years ago, there was a war between oxaliplatin and irinotecan, like a war between bevacizumab and cetuximab, panitumumab right now. And in the end, we all acknowledge we need all these drugs. We need oxaliplatin and we need irinotecan. And for all practical purpose, FOLFOX equals Xelox, which is capecitabine, oxaliplatin, and FOLFIRI. I don't use capecitabine and irinotecan because of overlapping toxicity. When biologics came about about 10 years ago, we thought this is going to revolutionize everything we're doing. They've added incremental benefits to patients' outcomes. We need them, but they haven't really improved our outcomes as much as we hope. But I think we're getting better, and I'll show you some things at the very end. Now, these are all the drugs that we need to use and that we have available, including best supportive care. And there's a new drug which you might not be familiar with, which is called TAS-102, which I'll talk about in a minute, which will get approved sometime this year, I hope, based on the phase 3 data FDA is currently reviewing. And the challenge now is how to make sense of all these different treatment options. We don't use these agents as single agent, we use them in combination therapies. We use sequential therapies, different lines of treatment, and we talk about the so-called continuum of care because we want to expose all patients to all active agents. And I think one of the critical issues that we need to talk about and need to remember is in colorectal cancer, we have not had one breakthrough event, like this one drug that really changes everything, like imatinib in GIST or imatinib in CML treatment. What we see, the advances we see, is kind of an addition of incremental benefits patients have received over time. And when you look at hazard ratios here, the hazard ratios, which is kind of the best kind of measure of improvement in a randomized trial, have been between, let's say, 0.7 and 0.8, meaning a 20 to 30% improvement in outcome, but not one breakthrough event. When we look at what happened over the last 10 years, and we look at overall survival compared to first-line PFS, 10 years ago, when you treated a patient first line covered 50% of a patient's life, 10 months. Patients lived 20 months. Nowadays, it's still 10 months. In spite of everything we've been doing, first-line PFS is still 10 months, but patients now live 30 months. It's 1/3 of what you're doing. We overestimate the importance of first-line therapy. The improvements have really come from subsequent lines of therapy, keeping patients on therapies, and that's why post-first-line progression therapies, how you organize this for your patient, I think is very important. Now, I'll be very careful here, trying to click the wrong button. We have 2 different biologics, types of biologics that we currently use in the treatment of metastatic colorectal cancer, which is anti-EGF receptor therapy and anti-VEGF therapy. And they target very different cell types with consequences for biomarkers. EGF receptor antibodies target tumor cells directly, the surface of tumor cells. Tumor cells are genetically unstable, and you know that there are mutations inside the tumor cells which might render the treatment, antibody blockade on the surface of tumor cells not might render these cells insensitive. So RAS mutations, for instance, activate the downstream signaling pathway, and whatever happens upstream, EGFR receptor antibody doesn't matter anymore. Now for VEGF, anti-VEGF therapy, we are targeting genetically stable systems, the endothelial cells. There are no mutations. There shouldn't be mutations. And that's one of the reasons why we have not found a pre-treatment biomarker for anti-VEGF therapy. We don't know which patient will respond or won't respond to anti-VEGF therapy. Probably all patients will respond to some degree, but we have pre-treatment biomarkers here. Now let me go through some of the data. This is the trial that gave us bevacizumab about 20 years ago. IFL, bolus 5-leucovorin, irinotecan should not be used, toxic and not very effective. But the addition of bevacizumab really improved time-related outcomes. When you look at the PFS curve here, strong hazard ratio of 0.54, a 46% reduction of progression events. And you see these curves split early, they stay separated, then come back together. That's a very classic PFS curve. And I'll show you later a slide with a similar setting, first-line chemo plus minus biologic, where the curve looks very differently. Now, we have learned that duration of anti-VEGF therapy matters. And commonly, we use FOLFOX as first-line therapy or an oxaliplatin-based regimen, and we have to deal with toxicities from oxaliplatin because we have cumulative neurotoxicity. So one of the ways we can mitigate toxicity in first-line treatment and adding a biologic to the treatment is using an induction maintenance therapy approach, which I think is very critical for quality of life of patients. And we have data on the use of this maintenance therapy from the Dutch ICAHO 3 study, which was prominently published this year, the CAPOX bevacizumab treatment, 6 cycles, meaning 18 weeks. And if patients had at least stable disease, they were randomized to no treatment, chemotherapy for interval, or maintenance therapy with low-dose continuous capecitabine plus bevacizumab, fluoropyrimidine plus bevacizumab. And upon progression, patients were supposed to reintroduce CAPOX-Bev. And you have different endpoints. PFS1 is maintenance versus no treatment. PFS2 is when you allow CAPOX-Bev and then patients progress. But not every patient gets CAPOX-Bev. Some get irinotecan, so you have another endpoint. However you slice and dice it here, the outcomes were highly statistically significant with the exception of overall survival because the trial was not powered for overall survival. And I showed you first-line treatment only captures 1/3 of the patient's time of overall survival. So I really don't hold this against it. And they used a low-dose capecitabine regimen continuously, twice a day, 625 milligrams per meter squared per day, which I think is a very tolerable, very easy way for patients to get capecitabine. And these are the progression-free survival curves. That's as clear evidence that something's better than nothing. When you add a VEGF inhibitor to a fluoropyrimidine, you have a very strong effect. Now, I also mentioned duration of anti-VEGF therapy matters. We have 3 trials that use VEGF inhibition beyond progression with bevacizumab, aflibercept, and ramucirumab. And every single of those trials was positive for overall survival. It's a moderate effect with about a 20% improvement in overall survival, a hazard ratio of 0.8, 0.81, 0.82, and none of these drugs shows very much a different superiority over the others. So it's cross-trial comparison. We shouldn't do this. But I can tell you that the NCCN guidelines have embraced this and for cost reasons actually put in bevacizumab beyond progression as the preferred VEGF inhibitor beyond progression. There was a time when bevacizumab was an expensive drug. With $4,000 a month, we thought, wow, that's really expensive. Now we're talking about some of the pembrolizumab studies, $85,000 per month. $85,000 per month, $1 million a year. Ramucirumab, $12,000 a month. So if all of these are created equal, you take the cheapest. That's what it is. Now, we talked about capecitabine bevacizumab, IFL, FOLFOX bevacizumab. You can even use a triplet combination, FOLFOX, throw a kitchen sink at patients plus bevacizumab. In this TRIBE study, you have improvements in progression-free survival. You have higher response rate. And where should you use this? Aggressive therapy, potentially for aggressive tumors. And there's one tumor type, one molecularly defined tumor type in colon cancer, which is very aggressive, BRAF mutant tumors. We'll come back to that in a second. So this study actually singled out the BRAF mutant tumors, and this is a forest plot, and the more to the left these dots are, the better the treatment worked. And FOLFOXIRI bevacizumab had a very strong hazard ratio for patients with BRAF mutant tumors. Why is that important? This is the survival curve of BRAF mutant compared to BRAF wild-type tumors. If you like medians, 7.5 months compared to 25 months. These patients have very, very poor prognosis. They are in a high unmet need. 8% of patients with colorectal cancer have a BRAF mutation. You need to test for BRAF mutation before you treat a patient with colorectal cancer because FOLFOXIRI-Bev can make a difference, and we have a lot of trials for BRAF mutant tumors. The same mutation as in melanoma, and there was a paper just now in New England Journal actually this week that BRAF mutations are across the board, and they are to some degree sensitive to BRAF mutation inhibitors like vemurafenib, but what works very well in melanoma, 80% response rate, single agent, works hardly in colorectal cancer, 5% response rate. So it's not, even though this mutation drives biology, when you inhibit it, it's not all what you need to do. It's a different context. We all think, we're getting away from treating colorectal cancer or lung cancer or melanoma. We're treating BRAF mutant and HER2 and whatever tumors. We're developing pathway doctors. But that's not true. The tumor entity still matters. Now, what really seems to work in BRAF mutant tumors, you need to use a kind of a doublet or potentially a triplet, rational combination of chemotherapies or biologic agents with or without chemotherapy. What seems to work best is you need a BRAF inhibitor and an EGFR receptor inhibitor to kind of counteract feedback loops. And there's a trial ongoing right now, in US intergroup trial, looking at in BRAF mutant tumors, vemurafenib, cetuximab, irinotecan, versus cetuximab irinotecan. Very well accruing, should be closed earlier next year, and there are already registration trials planned for other BRAF inhibitors. One point that I like to make is, why should you test for BRAF mutation beyond just having a prognostic factor? BRAF mutation actually also probably and very likely make EGFR receptor antibodies not work. RAS mutation, we all have accepted that. It doesn't work when you use cetuximab and panitumumab in RAS mutant tumors. But in BRAF mutant tumors, a meta-analysis of all available data showed no benefit for patients in a recent publication in European Journal of Cancer. So test for BRAF mutation. It's easy to test. It's one mutation. So this all was kind of embedded in anti-VEGF therapy. I told you duration of anti-VEGF therapy matters. Treat to progression. Use maintenance strategies. Treat beyond progression. Be very mindful about toxicity, especially when you use oxaliplatin in first-line therapy. I'm very concerned about pushing patients too much into neurotoxicity because that's a side effect that might stick with them for the rest of their short lives. You should stop treatment before you hit neurotoxicity. When we use at Mayo Clinic, when we use FOLFOX, we never go beyond 8 cycles of FOLFOX in first-line therapy. And we never use a bolus with FOLFOX. So our regimen is modified FOLFOX 7 plus bevacizumab if you use bevacizumab. No bolus 5 if you stop oxaliplatin after 8 rounds of treatment, then use a maintenance therapy. 3 positive trials, phase 3 trials for prolonged VEGF inhibition, so really it's a price war, aflibercept, ramucirumab versus bev, and you can combine bevacizumab with FOLFOX here. Now let's talk about anti-EGF receptor therapy. And I told you we're hitting tumor cells directly. Hitting tumor cells directly has implications because, as I said, downstream signaling changes, makes these treatments not work anymore. If you have a RAS activation, RAS mutation, which is an activating mutation, whatever happens upstream, it doesn't work anymore. And I already talked about other factors like RAF. There are data on PIK3CA mutations, PTEN expression levels, ligand expression levels. It's much easier to develop a pre-treatment biomarker and a signature for patients that might respond or might not respond to the EGF receptor inhibitors because we're talking about tumor mutations, tumor alterations. Now, one of the most prominent studies that really put cetuximab on the market was the CRYSTAL study, FOLFIRI plus minus cetuximab, first-line study, large study, 1,200 patients with a PFS endpoint. And now I'll show you a progression-free survival curve, which looks very different than any other curve I've shown you so far. This is it. This is Crystal, the FOLFIRI plus minus cetuximab treatment, when we did not know about KRAS or RAS. And you can see these curves dance around each other. Heinz Lenz from UC says they hug and kiss for about 45% of patients, and then they separate. Whenever you see a curve like this, there is a subgroup effect. There's a subgroup patient that has no benefit. Now, going back to the IFL plus minus bevacizumab curve that I showed you earlier, where these curves separated early, stayed separated, and came back together, there's not a hint of a subgroup effect. You can look at any bevacizumab trial in first-line therapy in ovarian cancer, lung cancer, breast cancer, whatever. Look at PFS, there's not a single overlap like here. There is no pre-treatment biomarker for anti-VEGF therapy. We're targeting endothelial, genetically stable endothelial cells. We don't know how, it's not a qualitative biomarker. Yes, I know there might be a quantitative biomarker, but we don't know who that is. Now, if you adjust for KRAS, exon 2, now you see these curves separate earlier. You know, there's still a subgroup effect of about 15%, the other RASes that we now know about, and we'll talk about this in a second. But now the study all of a sudden is positive. Now you have survival benefit. Now you have progression-free survival benefit. Molecular selection for a drug that targets tumor cells directly. Now we have learned mainly from the Amgen, the panitumumab studies, that we need to go beyond KRAS exon 2, codon 12 and 13, to look at mutation analysis to select our patients. And you need to do this, and I'm sure you're doing this, that you test for mutations in exon 3 and 4 and NRAS mutations, exon 2, 3, 4, and, as I told you, about BRAF mutations. And you can see that the PRIME study here, and this is a very important study, FOLFOX plus minus panitumumab, published in New England Journal of Medicine. These are the non-mutated KRAS exon 2, the wild-type KRAS patients, but mutated in the other RASes. And when you treat those patients with FOLFOX panitumumab, you have a detrimental effect. You have a 29% increased risk of dying when you don't treat the right patient population, when you treat patients with RAS mutation, even when you do a KRAS test. So you need to have a comprehensive RAS analysis. Now, the big discussion at this point in time in colorectal cancer, or one of the big discussions, is what should you use in first line in RAS wild-type tumors, cetuximab or bevacizumab? And there are two studies which came sequentially within 1 year apart. The FIRE3, a German study, and being German, I can criticize it as much as I want. 600 patients, first line, with an investigator-rated response rate as primary endpoint. Very unusual endpoint for a phase 3 trial in first-line therapy. Now, interestingly, when FOLFIRI plus cetuximab versus FOLFIRI bev, I would have thought cetuximab really blows bevacizumab out of the water in terms of response rate, direct tumor cell hit. But the primary endpoint was actually negative, investigator assessed. Now, later, when they looked at central review, et cetera, cetuximab did have a higher response rate, and this is actually what I more expected. Progression-free survival, no difference whatsoever, and I think we didn't expect it. I mentioned, it's 10 months, has been 10 months for 10 years. We've never gone beyond 10 months. And then the interesting thing is overall survival. Overall survival, the hazard ratio of 0.77, curve split late at about 2 years. So this is first-line therapy here with PFS, and the curves separate about a year later. At the time of separation, the largest separation is carried by 13 patients. You have to keep in mind, the Kaplan-Meier analysis has a certain way of accounting for censoring events. So what happens here at about 36 months, when these curves separate widest, the separation is carried by 13 and then eventually 11 patients. So why is that? Why do we see this late split? So could there be imbalances in post-progression therapy? There's still some confusion and some concern. There was a recent JCO paper that tried to address that. I'm not quite sure whether I'm really buying this, but let's say all is fine. Could there be an optimal sequence? Bev works better after cetuximab than the other way around. Or could it be that there's a small subpopulation of colorectal cancer, remember these 13 and 11 patients, that really has a tremendous benefit, where the tumor is driven by EGFR receptor signaling, like HER2 is driving some breast cancers. And we don't know who these patients exactly are. We kind of eliminate those patients by looking at eliminating RAS mutation, eliminating this and that, and BRAF mutations. If that was true, when you now eliminate all the RAS mutations, because this was so far exon 2, the separation would be wider, and exactly that's what it is. So if you eliminate all the RAS mutations, you refine this patient population even further. Now you have smaller sample size, but the difference here, the large difference, is still carried by 13 and 11 patients. Now you have an even stronger hazard ratio. Now this was a secondary endpoint of a trial powered for response rate in first line. We need a confirmatory trial adequately powered for overall survival to see whether this is right or wrong. That's what statistics help us. Now we have this study, a US study, the intergroup study 8405 CLGB SWOG, which read out about a year and a half ago. And primary endpoint of this almost 1,200 patient study was overall survival. It's about twice as large as FIRE3. Allowed FOLFOX and FOLFIRI, most patients received FOLFOX 70%, and compared Bev versus cetuximab. And I can go through slides now very fast because there's absolutely no difference. When you look at PFS or overall survival, this is KRAS exon 2 selected patients, no difference. Now, here is overall survival with FOLFOX and FOLFIRI, no difference. Now, then you get the additional RAS mutation, eliminate another 15 to 20% of patients with RAS mutation, and still no difference in progression-free survival, in overall survival. You can look at it, whether you look at FOLFOX and FOLFIRI, has progression-free survival. You can look at overall survival, no difference whatsoever. Now, when you now compare FIRE3 and the CLGB SWOG study 8405 side by side, and they are more similar than different. Everything is about the same. No different. I mean, same readout in response rate, higher for cetuximab a little bit. Same readout in progression-free survival, no difference. And the overall survival here, it's 32 months, 31 months, 33 months, and 25 months. There's one outlier. The FOLFIRI-Bev arm in FIRE3 is the outlier. And we don't know why. Now, we have combined the data. We're analyzing these data sets together, and we will figure out why this arm is so inferior. For the US world, where the 8405 study was conducted, whatever use cetuximab or bevacizumab in first line in RAS wild-type tumors, you have options. You can select, you can pick and choose what you want. And I think that's great for us when you have options, and we should not make ourselves subjects of this commercial pharmaceutical war between cetuximab or bevacizumab. We're physicians trying to find the right treatment for our patients, and it's great that we have treatments available that push median survival now beyond 30 months. Regorafenib. Regorafenib is a salvage therapy or later line therapy drug, which was developed with the idea that when you treat patients for 2-3 years with standard treatments, tumors activate a lot of different pathways that drives their biology. So using regorafenib as a multi-kinase inhibitor against a lot of different pathways or a lot of different molecules made sense because it inhibits a lot of angiogenesis and kind of pathway markers, which could play a role in a later line setting when tumor cells develop markers of secondary resistance. The correct study randomized patients, regorafenib to placebo in a last line setting, 2-to-1. That's why patients really didn't mind the placebo randomization. You have 2 out of 3 patients have a chance to get the drug. The trial was supposed to enroll 690 patients in 26 months. It enrolled 760 patients in 10 months, 16 months ahead of schedule, identifying the unmet need. Those of you who run clinical trials, we sent a notification out 7 days before the trial was closed. We're going to close the trial in 7 days. We had 130 patients registered in 1 week. That's incredible. It shows you the unmet need of these patients in a last-line setting. The trial met its primary endpoint, hazard ratio 0.77, 23% reduction of death events. Progression-free survival clearly shows you not every patient benefits from this drug. There are patients who this is not a biomarker phenomenon in a last-line setting. This is a patient phenomenon. We looked at biomarkers, we looked at patient characteristics. If you have a patient who is too deteriorated with their performance status 2, these patients should not get regorafenib. Not every patient needs regorafenib. But if you have a PS0 or PS1 patient, those patients might benefit. Now, Kaplan-Meier curves are what we now use to look at when we talk about benefits for patients. There was a second study in Asia, a randomized study, which also showed a survival benefit for patients with regorafenib. And I'll show you their quality of life styles. You know, there's red curve is regorafenib, green curve is placebo. About the same. You know, it's good to see that the performance status doesn't deteriorate. But look at the numbers of patients that are able to fill out a questionnaire. 2-to-1 randomization, but you know, these are real patients. You see the numbers of patients here go from 53 to 4 to 3 to 1 very rapidly on placebo. You have to be alive to fill out a questionnaire. And sometimes we see Kaplan-Meier curves and we don't realize there are actually numbers of patients really behind it. The likelihood of patients to be able to fill out a questionnaire is much higher on regorafenib than on placebo. We have side effects, and you know, those of you who have used regorafenib know side effects. They come early, they come within the first 2 weeks. In my clinical practice, I do not use the package insert dose of 160 milligrams per patient. I think it's a mistake that Bayer made to push this initially too hard. I use an 80 milligram or 120 milligram starting dose for 1 week, and then I escalate, and patients tolerate this much better. So if you use regorafenib in your practice, use an escalating dosing scheme. TAS-102 is a new drug which is currently being reviewed by FDA. It's a fluorothymidine, so fluoropyrimidine with a different twist of action. It has an inhibitor built in. TPI is actually 2 drugs. Was initially synthesized in 1964 by Charles Heidelberger, the guy who gave us 5FU. Was considered not stable enough because it gets degraded so fast. So the trick is really to combine it with a degradation inhibitor, which also eliminates hand-foot syndrome, because hand-foot syndrome and fluoropyrimidines doesn't come from the fluoropyrimidines, but from the degradation products. So no hand-foot syndrome with this drug. It's incorporated DNA proliferation interference. Was tested 2-to-1 randomization, later line setting against placebo in a worldwide study. This is the survival benefit, hazard ratio 0.68, clearly there. 32% reduction of death events. Progression-free survival, you've seen curves like this. Only about 40-50% of patients really have benefit. And whether or not they had been pre-treated with regorafenib didn't matter. So if you had regorafenib pre-treatment and you went on to TAS-102, patients had the same benefit. Side effects are interesting. No skin toxicity, no diarrhea, perhaps a little bit diarrhea, no fatigue, neutropenia. And about 50% of patients have to delay the second cycle because of neutropenia. Very few patients have febrile neutropenia. Patients really don't feel TAS-102. A lot of my patients, we have an expanded access program. We have treated 41 patients with TAS-102 at Mayo. They say it's the best treatment we've ever had in terms of tolerability. Now, the efficacy, again, this is progression-free survival of TAS-102. I'll show you the progression-free survival of regorafenib, and you shouldn't blink too fast because that's regorafenib, that's TAS-102, that's regorafenib, that's TAS-102. It's exactly identical. It's exactly identical. It tells you more about the patient population in this last line setting than about the drugs. Now, here you can have this comparison. 2 trials with regorafenib, the Asian trial here, less heavily pre-treated patient population, better benefit. The TAS-102 and the regorafenib set. I think these drugs are virtually identical in efficacy, very different in their toxicity profile. Now, this is what we do, what we look at when we treat patients at Mayo Clinic. Molecular testing, you talk about a palliative setting, molecular testing. If you have any RAS mutation, which is 55% of patients, majority of patients now, you don't use EGFR receptor inhibitors. When you have all RAS wild type, you can use EGFR inhibitor or BEV. If we start with BEV, we normally prefer BEV beyond progression unless patients progress very rapidly, then we would use an EGFR receptor inhibitor in second line. But you can easily use EGFR receptor inhibitor first line, BEV in second line, and regorafenib is here. And for BRAF mutant tumors, you really want these patients in clinical trials. Clinical trials are important. You heard that before. And where TAS-102 will play a role will be interesting to see. It's not yet in any guidelines. We have to talk about immunotherapy, of course. Immune modulators, and I'll go through the background very fast because you already heard a lot about it. What I want to tell you, where does immunotherapy work? It works in tumors that have more mutations, that have neoantigens. We'll talk about the hypermutant genotype. Now, mutations can either be induced from exogenous toxins, cigarette smoking, sun. That's why it works. The immunotherapy works in some patients, melanoma in some patients with non-small cell lung cancer, because they have mutations. There was a paper in Nature Medicine recently in lung cancer where the definition of hypermutation was 200. It's kind of arbitrary, but they said it's more than 200 mutations compared to the normal cells. So that's more or less where the threshold is. So in colorectal cancer, we have a group, we have long identified a group that's hypermutated, the so-called MSI-high tumors, mismatch repair deficient tumors. Mismatch repair deficiency, of course, it kind of makes DNA repair deficient. So you have accumulations of mutations. From the Cancer Genome Atlas program, we have seen already, we have hypermutated tumors, mainly the ones Lynch-like syndrome. Not every hypermutated tumor is Lynch. They're more sporadic inactivation of these mismatch repair deficient cells, repair enzymes. But there is a substantial portion of patients that have hypermutation. And we've known for a long time that the immune system plays a role. You read these reports, stage 2 cancer, large tumor, no lymph node involvement, and your pathologist report said peritumor lymphocytic infiltration. We knew the immune system was there. And when you talk about MSI high tumor, we know the prevalence in stage 2 is higher than stage 3 and stage 4. In stage 2 tumors, it's associated with excellent prognosis, probably because the immune system can control them. And if they have so many mutations, they might be so deranged that they just can't metastasize. They die off. Now, once a clone has been selected to go into lymph nodes or in other organs, stage 3 and stage 4, you might have actually poor prognosis. In stage 3, these tumors do not have better prognosis. In stage 4, they might even have worse prognosis. Now, we have data, and you've heard about pembrolizumab and nivolumab and Keynote and Checkmate and trees and oceans and whatever. So what a very important presentation at ASCO for colorectal cancer and probably for other tumors was identifying the hypermutation phenotype as biomarker for the efficacy of PD-1 antibodies. So they looked at colorectal cancers and non-colorectal cancers, deficient in mismatch repair or proficient in mismatch repair, or MSI high tumors. And there are other tumors which are non-colorectal cancers which are deficient in mismatch repair. Those are, for instance, biliary tumors, endometrial, small bowel, prostate, gastric tumors. So mismatch repair deficiency can actually occur in a lot of different tumor types. And of course, most of these patients here in colon cancer were Lynch syndrome patients. And here they used pembrolizumab in the last line setting. And one of my colleagues at Ohio State, Rich Goldberg, said, for the first time in his life, he observed a Lazarus effect, kind of pulling someone out of hospice into long-term complete response. And if you talk about biomarker response, which is nice to graph here, those patients in green are the mismatch repair deficient tumors, in red are the mismatch repair proficient tumors. That's a biomarker. We're not talking about PD-L1, which is probably a little bit more difficult, but mismatch repair deficiency, the amount of mutations per tumor cell is a biomarker. Objective response, mismatch repair deficient, whether you're colorectal cancer or not, you have the same response, a similar response rate, mismatch repair proficient, no response. And you like, waterfall plots, you can look at whatever you want. Here, mismatch repair proficiency versus deficiency. Overall survival here, these curves separate very nicely. Now, the consequence is, and the NCCN guidelines will incorporate this, every patient with colorectal cancer needs to be tested for MSI high. Beyond just looking at Lynch syndrome, but identifying those patients who might be candidates for immunotherapies. 2 years ago, I made a slide, and I'm happy, not that I tell you I told you so. This is kind of what I came up with, top 5 novel polls. This is 2 years old. And I said, BRAF mutant tumors, we need to single them out. Hypermutated tumors with PD-1 and PD-L1, the idea of neoantigens was already kind of coming up. HER2, we now know about 5 to 8% of patients with metastatic disease have HER2 overexpression, and we have a 35% response rate when you use trastuzumab and lapatinib in combination in the last line setting. So in the end, you need to test, if you really want to test all these patients, and identify these 15 to 20% of patients. The biomarker panel that I would suggest for you for colorectal cancer is, of course, RAS, of course, BRAF, that's a given, MSI high, HER2, that's what you need to do. And for studies, even ALK-ROS, etc. And these are biomarkers which are available in every single molecular pathology lab. So conclusion, survival of patients has really improved a lot. But it's not this one event that really drove everything. It's kind of the addition of incremental benefits that patients have seen. Patients really benefit from receiving all active agents. That's our art of oncology, to making sure that patients can receive these agents in a sequential manner. And we are targeting these subgroups of patients with more sophisticated, more intelligent approaches. Now, really what happens right now, this is kind of what a classical case of colorectal cancer is. You might have 5 months induction therapy here, then you give 6 months of maintenance, and you might reintroduce the treatment, go second line, you might go beyond progression, whatever. You give patients a break of therapy, you have a third line, you might re-challenge with FOLFOX and whatever you want, and then patients die, and it's 30 months. Not one breakthrough event. This is the art of oncology right now in colorectal cancer. 15 to 20% of patients will branch out here and have perhaps breakthroughs, perhaps. Thank you very much.